Hello students, I am Mr. Manish Tadke, Associate Professor at Dr. Vittal Rao Vikhe Patil Foundation's College of Nursing, Ahilanagar. Today we are dealing with the topic rheumatic fever. Rheumatic fever is a systemic inflammatory disease that occurs following a group A beta hemolytic streptococcal infection, such as streptococcal throat. Now it is characterized by a combination of clinical manifestations including carditis, arthritis, chorea, erythema marginatum and subcutaneous nodules. The etiology of acute rheumatic fever is systemic disease of childhood, often recurrent, that follows group A beta hemolytic streptococcal infection. Now, this is a delayed non-suppurative sequelae to upper respiratory tract infection with group A beta hemolytic streptococci. This is a diffuse inflammatory disease of connective tissues, primarily involving heart, blood vessels, joints, subcutaneous tissues, and central nervous system. Looking at the epidemiology, ages from 5 to 15 years are most susceptible. It is rarely occurring below 3 years of age. Girls are more commonly suffered than boys. This is common in third world countries. Now, environmental factors involved here are because of overcrowding, it can occur because of poor sanitation and poverty. The incidence is more during fall, winter, and early spring. Pathogenesis of acute rheumatic fever. Now, this is a delayed immune response to infection with group A beta hemolytic streptococci. After a latent period of 1 to 3 weeks, the antibody-induced immunological damage occurred to heart valves, joints, subcutaneous tissue, and basal ganglion of brain. Now, by this we understood that this is an autoimmune process which is taking place here because of the infection of group A beta hemolytic streptococci. It initially causes sore throat, and the sequelae of the sore throat will be heart or any other connective tissue involving joints or subcutaneous nodules and then central nervous system. The clinical features, mainly we have to discuss about Jones criteria, where some major manifestations and minor manifestations have to be discussed. Now, the major manifestations, first comes the arthritis. Now, this is migratory polyarthritis, which involves major joints, commonly involving knee, ankle, elbow, and wrist joint. It occurs in 80% of the cases who have got infection of group A beta hemolytic streptococci, which involve joints. The joints are tender. They show redness, pain, swelling, limitation of movement. In children below 5 years, arthritis usually is mild, but carditis is more prominent. Now, what is carditis? The manifestations of carditis, they are involving all the tissues of the heart, and it causes endocarditis, myocarditis, and pericarditis. All the layers of the heart are involved here. That is why it is called as pancarditis. It occurs in 40 to 50% of cases who have got infection of group A beta hemolytic streptococci. Sydenham chorea is the third major manifestation. It occurs in 5 to 10 cases of infection with group A beta hemolytic streptococci. It occurs in 3 months after the onset of rheumatic fever. Clinically, it is manifested as purposeless jerky movements, deranged speech, muscular incoordination, awkward gait, weakness, emotional disturbance, dropping things what he or she is carrying. The next major manifestation is erythema marginatum. It occurs in less than 5% of cases with infection of group A beta hemolytic streptococci. It is a unique lesion of 1 to 2 inches in size with pale center with a red irregular margin. The next major manifestation is subcutaneous nodules. It occurs in 3 to 20% of the cases with group A beta hemolytic streptococci. Now, this is a late manifestation which occurs 6 weeks after the onset of rheumatic fever. Now, this is painless, pinhead to almond size palpable nodule. Mainly, it is over extensive surfaces of joints, spine, scapulae, and skull. It is associated with strong seropositivity, and it is always associated with severe carditis. The other features, which are also called as minor manifestations, minor features, which involves fever, a low grade rarely above 39.5 degrees Celsius, and which is present in 90% of cases initially, which are infected with group A beta hemolytic streptococci. The other thing is arthralgia. This is a subjective pain of the joints, pallor, anorexia, and loss of weight. Laboratory findings which are involved here for the diagnosis of rheumatic fever, where there is high erythrocyte sedimentation rate, the patient will have anemia, leukocytosis, then elevated C-reactive protein, and anti-streptolysin O titer, where it is more than 200. Anti-DNase B test is required, and throat culture to detect the group A beta hemolytic streptococci. Laboratory findings also involves ECG, where we can assess the prolonged PR interval, and in echo studies where valve edema, mitral regurgitations, and left atrial and left ventricular dilatation, pericardial effusion, decreased contractility can be detected. Diagnosis of rheumatic fever is mainly a clinical diagnosis. It is diagnosed on the basis of modified Jones criteria. We have seen the major manifestations which are involved in Jones criteria. Those are carditis, polyarthritis, chorea, erythema marginatum, Sydenham, and subcutaneous nodules and Sydenham chorea. The minor manifestation which are involving the fever, arthralgia, and the what we call as the ASO titer, we have to assess. Now, the presence of two major manifestations here are required, or one major manifestation and two major manifestations are required, which indicates a high probability of acute rheumatic fever. Now, it has to be supported by the evidence of presence of group A beta hemolytic streptococci. About treatment of rheumatic fever, we have to look after the primary prevention. It can be prevented after the identification of streptococcal sore throat, and the treatment has to be started with oral penicillin for 10 days. Secondary prevention can be achieved by injection of benzathine penicillin, which is given intramuscular 1.2 million units per 3 weeks or 0.6 million units per 15 days. Now, this is a painful injection which is given intramuscularly, and this is a long-acting injection. Treatment in the first step, the primary prevention has to be done, which causes the eradication of streptococci. In the second step, anti-inflammatory treatment like aspirin and steroids are to be given. In step 3, supportive management and management of complications have to be done. And in the step 4, secondary prevention with recurrent attacks can be achieved. Now, according to the clinical condition, we can recommend drugs. Where in the case of arthritis, aspirin can be given. For carditis, prednisolone is a steroid can be given. In the step 3, supportive management and management of complications like bed rest, treatment of congestive cardiac failure, and treatment of chorea with diazepam or haloperidol, and rest to joints and supportive splinting is required. Prognosis of rheumatic fever, where rheumatic fever can recover whenever the individual experiences new group A beta hemolytic streptococcal infection, if not on prophylactic medicines. Good prognosis for older age group is seen, and if there is no carditis during the initial attack. Bad prognosis for younger children and those with carditis with valvular lesion. So this was all with rheumatic fever. Thank you very much.